from him. We're going to talk about some of the new ways to manage structural heart disease today. It's a big topic. It's emerging, growing rapidly in interventional cardiology. I have no financial interest in any of the companies related to this talk, but truth in advertising, I am an interventional cardiologist, not a heart surgeon. And I prefer non-surgical, minimally invasive solutions for patients because they recover faster, they go home sooner, and they are often better off. Sorry, Dr. Canini is not here to rebut all this. The goals today are really to understand catheter-based approaches to valvular heart disease, aortic and mitral valvular disease. And I think, as was discussed earlier today, to discuss a new treatment option that has recently been approved for payment by CMS to treat our patients with high-risk AFib who are suboptimal candidates for anticoagulation. This is really the transformational concept in cardiovascular medicine in the past 5 to 10 years, and that is the construct of the heart team. It used to be that I, as an interventional cardiologist, whatever I said in the lab went. Same for surgeons. We now scrub with each other. We now listen to our echo people very carefully during procedures, our anesthesia colleagues. We meet several times a week to discuss complex patient subsets and presentations. And we decide the best treatment algorithms for individual patients, particularly when it comes to valvular heart disease. And this has really helped all of us. It's helped us grow professionally. It's helped us collaborate. And we think it's leveraged better outcomes for our patients. And we'll share some of those with you here today. It includes interventional cardiology, cardiac surgery, echocardiographers, valve clinic coordinator, and hospitalists. In fact, I think somewhere in the room today, yes, Tracy's here. Tracy is our valve clinic coordinator. If you have valvular patients that you think may benefit from evaluation by us, let Tracy know. And I promise you, she's 3 weeks ahead of BJ and me. She knows about all of our patients, and she is helping plan optimal treatment and testing algorithms to get them presented in our clinic. So let's talk about the prevalence of moderate and severe valvular heart disease. This comes from the Mayo Clinic. The upper panel is a nationally based frequency population incidence profile, or prevalence profile, I should say. And the bottom panel is Olmsted County. And you can see that there is an increasing prevalence of moderate to severe aortic and valvular disease in patients, particularly as they age. And as the baby boomers are upon us, this is a growing and massive problem that we will all deal with on a daily and weekly basis in clinical practice. You can see there's a higher incidence of mitral disease. We'll talk about that, and a significant incidence of aortic valvular disease. And you can see what happens to mortality in patients with and without valvular heart disease. If you have valvular disease, your 10-year mortality is significantly worse than if you do not. And we believe there is a tremendous undertreatment opportunity in this country to help patients with significant valvular heart disease. So we've divided the talk today into 3 different subjects. The first will be mitral disease, and we're going to talk a bit about aortic valvular heart disease, and finally we'll get to high-risk atrial fibrillation. Let's take a look at the prevalence of mitral valvular disease from the end of the first decade of this century. You can see there are about 4.1 million patients with mitral valvular disease. Those eligible for surgery, about 1.7 million people roughly, but only 30% get mitral valve surgery annually, which means we're treating the tip of the iceberg. Only 2% of the patients, 84% of patients are untreated, and there is a large treatment gap, evaluation gap for these patients. So there's a large opportunity to manage and treat more qualified patients. These patients are left untreated for a variety of factors, including impaired ejection fraction, high output risk, multiple comorbidities, and age. Of the surgical candidates, 50% are not referred, even if there is a surgical indication. So again, we have plenty of opportunity to help manage these patients. So what are some of the pathologic causes of mitral valvular heart disease? We break it down into degenerative and functional. Functional is easy. Those are people with stretched out ventricles from dilated cardiomyopathies or myocardial infarction. The ventricle stretches, it stretches the mitral valve apparatus, and then you have leakage of the valve shown on the far right panel there. There's also degenerative mitral valvular disease, which is known as primary or organic mitral insufficiency. This is caused by an anatomic defect with mitral valve prolapse, myxomatous changes, flailed leaflets, torn chordae. So this is the kind of thing that we refer to as a degenerative valve. What about the natural history of patients with valvular disease? You can see a very long latency of subclinical or asymptomatic presentation lasting years. But with mitral disease, once you start to develop symptoms, your prognosis is quite poor, with or without surgery. So surgery in those patients is often too little too late. And you can see with the onset of heart failure that the 5-year survival of patients with mitral valvular disease is quite low, approximately 10%. But if you have no congestive heart failure, you survive a much longer period of time. So I'm going to talk to you about a new technology that is available to non-surgically treat patients with severe mitral insufficiency. It's called the mitral zone. This is the first technology in its class, and it's got good clinical evidence to support it. It establishes vertical coaptation by drawing leaflets together. We can reposition this while we're actually deploying the device. We spend a great deal of time actually thinking about where along the line of coaptation to place the clip, and oftentimes we place a second clip to reduce the leakage of the valve. So again, in the room, you've got an interventional cardiologist, a heart surgeon, an echocardiographer, and an anesthesiologist. And we're all working collaboratively to figure out the best way to put this device in and to reduce mitral insufficiency. And the Everest clinical trial, which has been out now for a number of years, is the first trial to really support the use of this device in this patient population. So medical therapy is really limited and does not often change mortality. It can improve symptoms, but doesn't drive mortality change. Mitral valve surgery is a very good option, but many of our patients today, as you can tell by the aging baby boomer population, many of our patients are poor candidates for surgery. So there is a significant gap between our medical approaches and the surgical approach. And the mitral clip is really a technology solution, a percutaneous technology solution that helps us treat an expanding population of patients. So you can see what the device does. On the right-hand panel over here, the device comes up through the vein at the top of the right leg. We make a puncture in the infraatrial septum. We cross over the septum, and we deploy this clip. And instead of there being a single orifice, we make this a dual orifice. A innovative Italian heart surgeon, Atrial Fibrillation, approximately 25 years ago, innovated this surgery to repair degenerative mitral valves. He had tremendous success, and this is now translated from an open surgical procedure into a percutaneous approach that can help these patients. You can see the clinical data. In the United States, it's Everest 2 and Everest 1 trials. You can see that most of the patients in the Everest 2 pivotal trial, which won FDA approval for this device, had degenerative mitral insufficiency. Europeans are further ahead of us. They're actually using the device in functional mitral insufficiency. That is, people with stretched ventricles from heart attack or cardiomyopathy. Currently in the United States, we really can only do this outside of clinical trials for patients with degenerative disease, not functional disease. And in the Everest 2 randomized trial, approximately 280 patients at 37 sites randomized 2-to-1 microclip versus surgery. You can see the majority of them had degenerative MR. You can see they all had reasonably good ejection fraction. A fair number of them had prior cardiac surgery. There's a high incidence of functional 3 and 4 symptoms, Heart Association class 3 and 4 symptoms, and atrial fibrillation. They're generally older and high history of heart failure, which is what you would expect. You're treating patients with heart failure. We need to have improved functionality. So what did this randomized clinical trial show? It showed that there's significant reduction in mitral insufficiency, superior safety with a mitral clip compared to surgery. Now let's pause on that. What is that safety endpoint? The safety endpoint actually was bleeding. Obviously, getting a percutaneous procedure is less bloody than getting a sternotomy. So that's really what drove the lower major adverse event rate in the mitral clip arm. There's clinically significant improvement in New York Heart Association functional class and favorable reverse LV remodeling. And this is a big deal. Both surgery and mitral clip can deliver this. Surgery delivers it more reliably. Well, what happens when you clip a valve and you reduce mitral insufficiency is the ejection fraction ultimately improves and the filling at end diastole and end systole also shrinks. The volume shrinks. So basically you're shrinking a ventricle back down to its normal size, thereby improving cardiac output in a forward flow manner and improving outcomes. So this was published in the New England Journal of Medicine. The summary really is, compared to surgery, percutaneous repair had superior safety with similar outcomes. Surgery is a bit better overall at giving you more complete mitral MR reduction. At the end of 2 years, 78% of the percutaneous patients are free from surgery. Both arms in this study demonstrated meaningful clinical benefits through 2 years, and there was no loss of device integrity for 2 years. So it's actually a durable result in the near term. And again, if we're talking about highly selected patients who are poor surgical candidates, and those are the ones that we select, this actually is a nice treatment gap that we currently need to address in clinical practice. So what about the European experience in the European Access trial? They assessed nearly 600 patients with a follow-up of almost 500 of them after a year. You can see that they were older. You can see that they were mostly male. They had severe mitral insufficiency. The majority had class 3 or 4 heart failure, and unlike the Everest trial, the majority of them had very poor ejection fraction, less than 40%. And this is the treatment population that does badly whether you operate on them or not. Once the ejection fraction gets below 60% of mitral insufficiency, you've got real bad problems in terms of longevity, even if they have a successful operation. So the treatment trick here is to intervene sooner before the ejection fraction falls apart. And in their experience in Europe, there's a significant reduction in mitral insufficiency. Again, great safety with low adverse events rates, significant improvement in New York Heart Association functional class, and significant improvement in 6-minute walk test. So for even a functional group of mitral insufficiency patients, this device has a role. In the United States, there is the COAPS trial, which specifically now is looking just at functional MR patients, i.e., again, those with dilated cardiomyopathy or prior heart attack. And that trial is nearing the end of enrollment. I'm told that they should be enrolled by the end of this June. The first data points will probably be out this fall at TCT, and then next spring at the ACC and transcatheter valvular therapeutics. We now actually even have meetings that are just devoted to just 4 or 5 days of learning how to fix these valves. It's pretty cool to see how this has changed in a few years. And in the United States, we have a registry post-commercial deployment for our experience with mitral valve repair. This is a collaboration with the Society of Thoracic Surgery, the ACC, CMS, hospitals and medical industry. It's done through a national registry. You can see the patients selected generally have a pretty good ejection fraction of 56%. The vast majority have severe grade 3 or 4 mitral insufficiency. The vast majority have degenerative mitral insufficiency. There are a few functionals that somehow snuck by the entry criteria. There's a fair amount of mitral calcification, leaflet calcification, and there's a fair amount of severe right-sided failure as well. And you can see in this bar graph that clip implantation from baseline resulted in significant reduction in grade 3 to 4 mitral insufficiency, and the majority of patients post-clip had only grade 1 or 2 mitral insufficiency. Pretty good results, given that this is a non-surgical approach. Procedural success, nearly 92%, about an 8% complication risk, length of stay is about 3 days in their homes, and almost 82% of people go home after this procedure. Adverse events in a real-world commercial experience. In hospital mortality is about 2.5%, 30-day mortality fairly low at 6%. Very few people need emergency surgery, low risk of stroke, infarction, major bleeding, perforation, and there are rare events of the device peeling off one leaflet or even peeling off altogether and embolizing to a different part of the body. So, in a prohibitive risk patient population, we have a 92% success rate with adverse event rate of less than 3% and mortality of about 2.5%. Procedural complications overall less than 8%. And again, we've got better end-diastolic dimensions, reduction in MR, better ejection fractions, and better left ventricular volumes overall. We'll shift gears now to aortic valvular disease and talk about some of the real progress that's happened there over the past decade. Parenthetically, there are 2 major devices on the market. We're going to talk about the device that we use for the majority of the time today, and that's the Edwards device. But a few weeks ago, when we were putting in the core evolute valve from Medtronic, I got to meet one of the pioneers who flew from France to help us, Jean-Claude Board. Very cool guy, very cool experiences. He's been at this since 2002. He represents the Medtronic arm, and his collaborator, Crevier, teamed up with Edwards. Now the 2 of them are collaborating. These devices are being selected for the right patient population. So hearing his experience and having a cure to coach BJ and I through some very complicated cases in the new device implementation was really quite cool. Let's talk about aortic stenosis for a minute. The disease continuum spans from a normal valve, of course, to aortic stenosis, which is mild thickening of the valve, no obstruction of flow, and severe calcification, impaired leaflet motion, and obstruction of blood flow. This is a slowly progressive disorder. This is an active disease. This is not just wear and tear. You get lipoprotein deposition of the valves, you get chronic inflammation of the valves, and the leaflets become calcified. Some years ago, people talked about using lipid-lowering drugs to slow the progress of this disease. That never has borne out. Not to say that you shouldn't have these patients on lipid-lowering drug, because as you know, and as you've seen, many of them have closes and coronary disease, and you need to treat them for that. But the teaching point, of course, is that lipid-lowering drugs does not change the trajectory of aortic stenosis. So here is a diagram of a healthy valve on top and a diseased valve below. Calcification and mobilization of leaflets from stiffening and narrowing and decreased valve opening and reduced cardiac output. The causes are associated with aging, which is the most common cause we see, inflammation, possibly lifestyle, that's very speculative, and we see a number of people with congenital or bicuspid valves that lead to premature aortic stenosis, usually in the 6th and 7th decades that require operation. So what is the pathologic process? And it's useful to remind all of us about this. The orifice is gradually restricted. A marked pressure gradient develops so that the pressure inside the ventricle is much higher than it is in the aorta. In order to preserve output, ventricular pressure must exceed the aortic pressure to resist ejection. The left ventricle responds with hypertrophy, so it becomes very, very thick, and it leads to increased oxygen consumption. So, this is a common disease that occurs in 25% of the patient population over the age of 65, and almost half the patient population over the age of 84. This, again, is becoming almost an epidemic. You may or may not hear a heart murmur on exam. In older patients who are frail and tend not to do much, limited by arthritis, you may or may not even detect symptoms. This disease is associated with increased morbidity and mortality, even when we control for other risk factors. Exertional chest pain, lightheadedness. I saw an 85-year-old gentleman a couple of weeks back who had gone to visit his sister-in-law in a hospital, and they parked out in the parking lot 100 yards from the front door of their hospital. He's trying to keep up with his younger brother, and he says he just lost power to the point when he hit the front door and he passed out. Sure enough, his valve area is less than 0.5 centimeters squared, and his gradient is 50 millimeters across that valve. So syncope was his presenting finding. And again, you can see this is a disease with a long, latent period. The survival after the onset of symptoms is 50% at 2 years and 20% over 5 years, with the shorter survival being after you develop heart failure. So if you have heart failure and aortic stenosis, you have big time trouble. The chances are you won't make it 2 years. You can see with angina, you have a slightly better survival of several years, and that probably has to do with the wall stress function of aortic stenosis, increasing myocardial oxygen demand. And you can see that surgical intervention really should be performed and is recommended promptly, even when symptoms, even when minor symptoms develop. So after the onset of symptoms, the average survival again is 2 to 3 years with a risk of sudden death. The development of symptoms per our guidelines, corrective surgery is generally indicated when we have even mild symptoms. And it has been said age is not a contraindication to surgery. The old teaching before we had the percutaneous approach was that we could operate safely on patients into their 90s, provided they were clean surgical risk. In evaluation, of course, the cornerstone of the evaluation here is an echocardiogram, which can give you great hemodynamic information about leaflet restriction, the gradient across the valve using the Bernoulli formula. It can also help us define coexisting abnormalities with other valvular heart disease or with LV dysfunction, and it is a good and reliable marker for ongoing evaluation. So if patients come in and have moderate aortic stenosis about every 12, 18, 24 months, depending on how bad it is, they should probably have another echocardiogram to see how this is progressing. And I want to just pause for a second here and just talk a bit about mortality from this disease compared to some of the other things we see in clinical practice. I told you a minute ago about my patient who had syncope walking in the parking lot. Among other things that we discovered when we evaluated him, he has a hypermetabolic mass in his right upper lung. So he has probably a stage 2 lung cancer. You can see that the mortality, or the survival, I should say, from aortic stenosis is quite low compared to ovarian cancer, prostate cancer, breast cancer. Even in my patient with lung disease, before I came over here today, I got off the phone with the oncologist to talk to her about my patient. She thought he had a 3 to 5 year survival based upon the clinical information we have. Well, that means that he probably should get a transcatheter aortic valve before we deal with his lung disease, provided, of course, that's what he wants. We're going to talk to him about that. But this disease really does shorten your life compared to many of the cancers that we treat. And you can see, with or without symptoms, the aortic valve replacement does better than no valve replacement. You can see survival over the course of months. So the aortic valve replacement really does help these patients live longer with better functionality. And this really is a problem of aging, and it is increasing in almost epidemic proportions. More patients have advanced age, they are frail, they have severe comorbidities. Operative intervention is more complicated and risky in this patient population, and there is no medical treatment. The medical treatment alone does not work. There really is no medical treatment. This is a mechanical problem with only mechanical solution. Sure, you can diurese them and make them feel a little bit better, but do not change mortality with some of the medicines we give, which is actually palliating those patients. The only solution for aortic stenosis is a mechanical solution. And if we look across the decades here, we see that there is tremendous undertreatment of aortic valvular disease. At least 40% of patients do not get a valve replacement. And you can see this is across a number of different studies from a number of different groups. And the reasons that patients have been steered away from valve replacement have been patient family decision. I had one of those in the hospital. We decided for hospice. I'll be sent him there today. Physician's clinical judgment. And again, that probably has to do with how well you think they might survive an operation and how they might come out on the other end. And that's the diagnosis of inoperability based upon those severe comorbidities and frailties. So there are really good options today to treat the patient population. Since Phelan and Crivier in 2002 presented a TCT, the transcatheter aortic valve procedure, our technologies have improved, operator skills have improved. In fact, it's so easy now, let me do it, so it must be pretty easy. We've actually done something very innovative, and that is we collaborated with CMS and with national registries to really look at our outcomes. We get our own report cards now every 4 and 6 months. We're looking at what we're doing, and we're trying to decide how to make our patients get these procedures done more safely, more efficiently, and get them back to better functionality. And I promise you, we now have a monthly meeting where we sit and we chat with our executive leadership at the hospital, looking at all of our safety parameters, including this one, to see how we can actually improve performance for our patients. What are the inclusion criteria? Aortic stenosis defined as a valve area of less than 0.8 centimeters squared, or a mean gradient of greater than 40, and velocity jet of 4 meters per second. Now, this is for the typical patient with classic echo findings. Be aware that there are a group of patients that have low flow, low gradient, severe aortic stenosis with poor ejection fractions. And we should be evaluating those because many of those actually do benefit from this technology as well. Usually they have advanced New York Heart Association functional class 2, 3, or 4. They have a risk of serious death or irreversible morbidity from AVRs assessed by a cardiologist and 2 surgeons. Now, this is from the original partner data, must exceed 50%. The data I'm about to show you here today will get us down to about 5% risk. We used to think 5% risk was not too bad for surgery. Now 5% risk may be a little bit too high, and maybe we're talking about, particularly these older patients, using a transcatheter valve. To date, the NCD, the National Coverage Determination, suggests that we have to have two surgeons say that the patient is inoperable or high risk before we can proceed with the catheter-based technology. You can see the progress and the structure of the valves. The big deal is the access site from 24 French down to 14 French. That's a big deal when you're navigating from the femoral artery to the heart. You can see there's a change in the structure of the valve. On the next slide, we see the features of the current generation device. And the major innovation is this outer skirt that reduces the leak of reduces the risk of perivalvular leak. So there's less leakage, less aortic insufficiency when we're done. We'll show that data here. This is a low-volume pericardial tissue valve projected to last 10 to 15 years in patients. And then there's some enhanced geometric considerations that Edwards designed related to this, the frame and strut structure that lets us have access to like coronary arteries and everything. So it's a very, very cool device. We've done a lot of homework and learned a lot of lessons in the past 13 years. So from the PARTNER 2 trial, where we looked at the latest generation of the SAPIEN 3 valve, you can see the average STS score, that is the risk of mortality, was 5.3%. The average age was nearly 82. Most patients had a transfemoral approach. We had some transaortic and transapical patients, but very few. You can see that the majority of patients get 23, 26, or 29 millimeter valves. You can see that many of them are New York Heart Association class 3 or 4. They've had prior CABG, they've had prior stroke, there's peripheral vascular disease, frequent diabetes, oxygen-dependent COPD is not trivial, particularly in a high-risk population. Many of them have chronic kidney disease, atrial fibrillation, and frailty, a high-risk group frailty. If you're frail, if you can't walk 5 years, if you don't have good grip strength, if your albumin is low, if you don't do well on the mental status exam, you really ought to pause before you start putting those people through big procedures. And maybe this is a viable alternative in a well-informed patient and family, particularly for those people who have markers of frailty. And you can see the mortality, all-cause mortality, 2%, cardiovascular mortality, less than 1.5%. This is a high-risk patient population. Stroke risk is quite low. This slide actually gives you the breadth of experience from the early generation transcatheter valves down on the left to our most recent experience. You can see all-cause mortalities drop from about 6% down to a very low 1% with these transcatheter valves, including a very high-risk patient population that's frail. I think that's a very cool and compelling story and a very insightful story related to innovation in the space. All strokes gone from about 7% down to maybe 2.5% or less. So this is really, really a great innovation and advance with these devices. Other clinical events, you can see that major bleeding risk is less than 6%, or major vascular complications less than 6%. Bleeding, pretty low. Rupturing the aorta is now down to almost a reportable event. Rarely do we have any myocardial infarctions or coronary occlusions. Kidney injury is much smaller because we use less contrast within the device. The only uptick really has been the uptake of the permanent pacers when we're done. The longer stent structure does tend to get in the LVL flow tract and into the bundle, so there's about a 10 to 12% risk of needing a permanent pacer after we're done with this procedure. Repeat reintervention is pretty small, and risk of infection is almost negligible. So you can see then what's happened to perivalvular leak at 30 days with the new valves, gone from 17 to 24% range down to less than 4%. So there's very little leakage once we put the new valve in. What are some of the conclusions from the PARTNER 2 trial? And this now I think has set a new goalpost in the management of patients with aortic valvular disease. In high risk and inoperable patients, the S3 system has low mortality and stroke and excellent clinical outcomes, even in intermediate risk patients, patients that we normally would send to surgery. We've actually improved mortality and disabling stroke. So those patients probably should now be considered more for this procedure, particularly when they're older and may have other medical issues. Other important findings: vascular complication risk is low, aortic rupture is low, coronary obstruction is low, valvular leak is very, very small, less than 4% for moderate leak. So what are some of the implications that we're talking about when we go to national valvular meetings? The rapid evolution of this balloon expandable valve and technical enhancements indicates at least parity with, and I would argue, superiority to some of the best surgical outcomes in intermediate risk patients. This procedure should now be considered as an alternative to surgery even in low risk patients with aortic stenosis, particularly older patients. I'm going to give you some of our experience here at St. Mary's as we started using the SAPIEN 3 device in October. Updated, this was, I think, through January. I think we've done 6 or 8 procedures since then. But the data is still very valid. We usually use a transfemoral approach. The case time, 80 minutes. And it's even better than that in the past couple of weeks. I can promise you that. We get general anesthesia. We usually do a cut down for the femoral artery, so very few of them get a fully percutaneous approach. You can see the size valve we use. And this is what our mortality and our major complication risk is. It's 0 and 0. So again, I think this is a signal of great collaboration through all the providers in our valve clinic, CV surgery, echocardiographers, anesthesia, and the entire team. They've all done a really good job working together to deliver this technology to our patients. This is just some of the other things that we see. Very low contrast use. We've had one patient who was very sick. He had ejection fraction of 15%, and we couldn't even open his valve. It caused him bad problems. We had to open his chest. BJ and Guru did that, and that went really well. And I'm told by his cardiologist that the patient is doing much better than he has in years. So again, really good results given the complexity of these patients. And you can see our valve leak rate, mild leakage, 5% or less in our cohort patients. So we're pretty happy with how this is going in our institution. Now to the final phase of the talk in structural heart interventions today, I'd like to turn our attention to non-valvular atrial fibrillation. I think that probably my partners were here today talking about an EP's perspective and AFib. You probably heard, did you hear Roy came already or not? Mm-hmm. And Roy probably talked about the novel anticoagulants. I'd like to put in a plug for those. I think warfarin is a thing of the past. Particularly in people with good kidney function, we should really stop recommending that drug. We should go to the NOACs. Particularly Xarelto, Eliquis, maybe Pradaxa. Those drugs are much better. However, there are a number of patients in whom anticoagulation is very problematic. Let's talk about atrial fibrillation, have a conversation about what some of the advancing alternatives are there. It affects about 1.5% of the population of the developed world. Lifetime risk in men and women over the age of 40. 1 in 4 will have some episode of AFib at one point in their life. The prevalence, as you can see, increases with age, with nearly 9% of the population over the age of 80 having AFib. Currently 2.5 million folks, and this is outdated data. It's not been updated recently, and assume with growing patient population, you could probably increase this by about 40 to 50%. You can see the projected rise in the incidence of patients with AFib through the Mayo Clinic data and through the Atria study. You can see that in non-valvular AFib patients, with 500,000 strokes per year, 20% of ischemic strokes do occur in patients with AFib, and this problem rises significantly, as you all know in practice, in the older patients, particularly those over the age of 60. I'm not going to talk about Shad's VAST scores. I presume that somebody else has done that with you today. You guys are all familiar with those tools that you can get online. They're calculators in the office now when somebody comes to see me and they have AFib. I actually pull the calculator out and we go through the calculator together and we have an informed discussion, shared decision making over what needs to happen for this disease and what drugs to select. So, warfarin is the cornerstone of therapy for stroke risk prevention in this patient population. So, assuming that you have, based upon population data, 51 ischemic strokes per 1,000 patient years, adjusted standard dose warfarin prevents 11 strokes at the expense of 11 fatal bleeds. Aspirin is much less efficacious. Warfarin, therefore, gives you a 60 to 70% risk reduction versus no treatment, and a 30 to 40% risk reduction versus aspirin. Well, warfarin, as you all know, is problematic. Slide I just saw recently, but I did not include in my slide deck here, is that at least a third of the time, patients are not well anticoagulated. They're under anticoagulated warfarin. We also have the other problem where patients are over anticoagulated. It has a narrow therapeutic window. And there are multiple drug-drug and drug-food interactions. It's hard to talk to a patient with coronary disease and say, you know, you need warfarin, and they say, but then I can't have the greens and the veggies you've been recommending to me for the last several years. And so it's a very problematic drug for patients to use and manage, and that's why I have actually come to prefer the newer anticoagulations for this indication. The drug has a long half-life. If they get an angioplasty, we have to give the triple threat therapy, which is very problematic, so aspirin, Plavix, and warfarin. There's a trial from Europe, which I won't show here, but that trial showed that after a short period of time, usually 2 to 4 weeks, we can peel off the aspirin and use warfarin plus Plavix and have good protection from stroke and the same protection from stent thrombosis. So you will often see that in our patients who go home with AFib after a coronary event. We will stop the aspirin after 2 to 4 weeks, depending on what we've done in the cath lab patient related to their coronary disease. The other issues with warfarin are compliance, contraindications, bleeding risks. You know all that. I'm not going to review it for you in great detail. You can see the use of warfarin in patients by age with non-valvular atrial fibrillation. Only 55% of AF patients with no contraindications have evidence of warfarin use in the past 3 months. Some studies vary from as low as 17% to 50%. Elderly patients with increased absolute risk are the least likely patients to be taking warfarin, and there are contraindications to the drug up to 40% of the time. I always pause when I look at this slide. Major fatal bleeding with age increases over the age of 75 to almost 3% per year. We see this. It's devastating when we see it. You can see the risk of intracranial hemorrhage, and it rises when you're super therapeutic, 3% with an INR greater than 4 and 10% with an INR greater than 4.5. So what is the stroke pathology in AFib? Insufficient contraction of the atrial appendage leads to stagnant blood flow, and then we embolize a clot from the atrial appendage. 90% of the thrombus is seen in the left atrial appendage. We usually identify this by doing a transesophageal echo. We can look at spontaneous echo contrast, clots, and velocity within the appendage. Here's a pathologic specimen. Down on the lower left, you can see an echo with a clot in the atrial appendage, and then you see this smoky, bubbly substance around it. That's called spontaneous echo contrast. That's pre-clot. It's just as dangerous and is a harbinger for thromboembolic disease. And then you can see the pathologic slides looking at the anatomic variants of the left atrial appendage. So there is a device that has recently been approved within the last 2 weeks by the FDA called the Watchman Device. This device is a parachute with some tines on it, and the device actually will go and get stuffed in to the origin of the appendage so that it would sit here and it would block off the flow of blood to the rest of the appendage and then block the formation of clot or even the egress of clot from the appendage to the brain, causing a stroke or other systemic embolism. So what are some of the pivotal clinical studies that define the success of this procedure. The first one was the PROTECT AF clinical study. It was a prospective randomized trial of the Watchman versus long-term warfarin therapy, 2-to-1 allocation device to control, 800 patients from 2005 to 2008. Follow-up requirements, transesophageal echo at 45 days, clinical follow-up, and regular INR monitoring. There is an ongoing enrollment and access for patients after the trial. What are some of the inclusion criteria? You have to be over the age of 18, documented non-dilated AFib. You have to have an eligibility for long-term warfarin without conditions that would require, without other conditions that would require long-term warfarin therapy. And you have to have a CHADS-VASc score of greater than 1. The exclusion criteria: class 4 heart failure, ASD or atrial septal repair, planned ablation procedure in the EP lab, symptomatic carotid disease, low ejection fraction, and the TE criteria of suspected or known thrombus or dense spontaneous echo contrast. So what are the trial endpoints here? Primary efficacy endpoint is all-cause stroke, both ischemic and hemorrhagic. Cardiovascular and unexplained death, including sudden death, myocardial infarction, arrhythmia, heart failure, stroke, systemic embolization of the device. The primary safety endpoint was device embolization requiring retrieval, pericardial effusion, we'll talk about that, intracranial hemorrhage, and any bleeding requiring transfusion. So what are the results of this device in an intention to treat safety analysis? You can see the device outperforms the control with respect to superior safety. So what are the safety endpoints? There's one safety endpoint where the device did not do well initially was pericardial effusion. In the initial experience, after the device went in, about 6 to 7% of patients would wind up with pericardial effusion that needed to be drained percutaneously. More contemporary analysis from the PREVAIL trial, which was just published in the past year, shows that risk is down under 3%. The other safety endpoints were stroke events, which were more serious in the group that continued on with Coumadin, not in the device group. And bleeding events were also frequent, more in the Coumadin group than in the device group. So, efficacy, stroke reduction, Watchman outperformed control. Hemorrhagic stroke, you're much better off with the device than you are with warfarin over the long range. And so the conclusion is that long-term warfarin treatment has been found to be effective, but is very difficult and has risk, as we all know. In this trial, we compared Watchman to warfarin, and we found the hemorrhagic stroke is significantly lower with the device. When hemorrhagic stroke occurs, you can see the death rate is quite high. All-cause stroke and all-cause mortality are equivalent to that with warfarin. There are some early safety events, particularly pericardial effusion, but now that we have experience over the past 7, 8, 10 years with the device, we've actually reduced the risk of pericardial effusion now down to 3% or less. So really the device does work and is a good alternative to patients who need warfarin for AFib. So my urging to all of you is if you have a patient who you think, I'm not sure, we're going to try warfarin, I'm worried about bleeding, this device is now available, and they only need the warfarin for 45 days after they get the device, and then they can come off of it. So for a number of patients, this could be a significant clinical advantage, and this is available. Hopefully, we will be offering this within the next 4 to 6 months on this campus. That's it. Thank you very, very much.
Yep, we have a few more. Here.
Thanks. John, back to aortic sclerosis, stenosis, and the progression thereof. I want to just make sure I understand correctly, because this is a change in what I'm understanding. I sort of get the idea that some people with aortic sclerosis progress to increasingly severe aortic stenosis. What I did not ever think about really was that all aortic sclerosis is potentially progressive disease and should be continuously monitored. Is that what you're saying? Or is it really just a subset that progresses and we don't really know why?
First off, people do progress at a variable rate. I have many patients in my practice whom the velocity across the aortic valves remain less than 3 meters per second. Watch them every several years. They're not going to progress fast if their velocity is less than 3 meters per second on the echo. So those people can get an echo probably every 2, 3, 4 years, depending upon how you think they're doing. They should be evaluated clinically with an exam. Once you get about 3 meters per second and they start to have other symptoms, you should be thinking really about every 12, 18, or 24 months, depending upon that patient subset. Mr. Breeden.
Thank you for your talk, John, because I think it's going to change the way we all think about mitral regurgitation, especially. It's going to change the way I practice medicine. My worries are more towards when I saw the graph, the left ventricular function remains pretty normal, and then it suddenly goes down.
Yes.
And one of the criteria for looking for a mitral clip or anything to be done with the mitral valve is ejection fraction going down, and the NYHA has 2. Yeah, is that right?
Yes, 2 or worse.
So what are your suggestions with respect to monitoring the mitral regurgitation, which we never actively thought of as such, because we knew it's there anyway, because of heart failure, it's a flow-related thing, and enlargement of the ring, etc., but not really valvular. What are your thoughts on monitoring the echocardiogram or any other kind of monitoring in clinical? What are your suggestions regarding clinical practice, basically?
Oh, sure. So I think that anybody who does not have a cardiology evaluation for mitral insufficiency should be seen by somebody, okay, in my department. And the reason is this is a very complex patient subset. Many of them have, functional mitral insufficiency from prior scar, heart attack, diabetic cardiomyopathy, and they would never be a candidate for surgical repair. We would treat them aggressively with afterload reduction. But for the people with more degenerative disease, they should get an echocardiogram probably annually, looking for their mitral insufficiency and looking at their ejection fraction. Once their ejection fraction hits 60% or a little less, that's the time really to talk to a cardiologist about whether that valve needs to be repaired, particularly if you see a ruptured cord or a partial flap.
I would also contend that we shouldn't worry too much about ejection fraction because it's all going up into the atrium anyway.
Correct.
Much of the ejection is going up there, so the effective ejection fraction is low, hence the NYHA is.
That's correct. That is correct.
Should I repeat this for the rest?
You're exactly right.
Yeah.
You could repeat it.
No, I'm just saying that the effective forward flow is reduced, and most of the left atrium serves as a low pressure sink in mitral insufficiency. So a lot of the ejection fraction is artificially elevated because of that low pressure sink. And that's a great understanding of that.
How's Medicare with this experimental?
They're paying for the mitral clip. They are paying for the mitral clip, and they're paying for the TAVR, and they recently released a affirmative payment decision for the Watchman. It's interesting that FDA approved the Watchman, but CMS would not pay for it. We talked about putting the Watchman in, but at the end of the day concluded, since it was really a non-inferiority play and it wasn't reimbursed, that we weren't going to take that on until we had broader consensus from the payers in the marketplace about it.
Any more questions?
Okay, thank you.